Hello, I'm Pat Lincourt. I am the Director of Practice, Innovation, and Care Management at Oasis, and I'm here to introduce Dr. Steve Kipnis and Rob Picciolo as they're going to do a presentation. Actually, this is Chapter 2 in a series on stabilization and withdrawal services in substance use disorder treatment. Dr. Kipnis is a medical doctor who has many years of experience in treating substance use disorders and specialized experience in treating withdrawal management in SUD treatment. Rob Picciolo is a social worker who has many years of experience in working with patients who have substance use disorders, and he also has experience on the policy side thinking about substance use disorder treatment and the inclusion of withdrawal management services into programs. Um, the the presentation that you're going to see focuses on withdrawal management as well as stabilization. And withdrawal management really means the management of symptoms of withdrawal that people often present with when they're coming into care. And stabilization is a broader term. It means stabilizing the entire person, and that includes ongoing symptoms of craving or urges to use, as well as some protracted experiences of withdrawal that people may have for weeks or even months into treatment. Dr. Kipnis is going to talk about medications that are specific to substances that people may be using and experiencing withdrawal from. And then finally, Dr. Kipnis and Rob are going to talk about the whole team and engaging the team in the treatment of individual patients and in bringing the withdrawal management and stabilization service into your program.
We want you to think of stabilization and engagement, that what we're looking to do is make the patient comfortable, not make them more anxious, more depressed, more in withdrawal, but really to get them stabilized and comfortable, and do that as part of a medical regimen. That it would be conducted under the supervision of a physician. And this is, in many cases, a change in the role of the physician in our treatment facilities, to have them be more actively engaged in medicating the symptomology that patients were presenting and stabilizing them when they first came into care. And we thought that with that stabilization, that patients would be more amenable to engaging in treatment, present less difficulty in dealing with other patients and in dealing with the staff, and really the expectation is remain in care a longer period of time. And the research shows that the longer patients stay in care, the better the outcomes tend to be. So that what we're suggesting here is that depending upon the setting that the person needs, depending upon the levels of support that the patient may need, regardless of them, one door is all that they need to access, that they should have access to medical services and medications regardless of what kind of care they're in.
Right.
And the 822 also gives us the ability to draw out treatment for a long period of time. That what we're talking about is a chronic illness where there may be frequent relapses. And by being able to transition from when you need medication to when you don't need medication to maybe when you need medication again over a long period of time in a service that can be flexible in providing a lot of different types of care, that this can all be accomplished in the outpatient settings.
So if I ask you, what are we attempting to achieve with this whole process?
Well, we want to have one door to treatment, that what's appropriate for you can be had in a variety of settings, that you can address non-complicated withdrawal. And by non-complicated, we mean?
You don't have a comorbid medical or psychiatric problem that needs to be addressed immediately. You're allowed to have comorbid medical and psychiatric problems that don't need to be addressed immediately, and that's fine. But the sick patient needs a higher level of care.
And by reducing the stress that the patient may be going through because of a rapid withdrawal, or really trying to get the patient immediately to be off of all medications, that when the patient is more comfortable, when these symptoms are being addressed, that the patient is more amenable to engagement and is less likely to split.
Absolutely.
And I think that the last piece is that what we're looking at is the treatment of protracted withdrawal, that this isn't going to be over necessarily in a short period of time. It gives you the flexibility to design care depending upon how the patient is responding.
So if I understand what you're saying, the goal essentially for day one is to get the person in addiction treatment, make them comfortable, make them able to take on this treatment and be successful with it. There are a lot of medications used for withdrawal treatment. There are a lot of different protocols. The protocols could be very complicated or it could be relatively simple. I happen to like the symptom-driven protocols. You tend to use less medications, though certainly the standard set protocols have been around for a long time and are used. The key to this whole piece of the withdrawal and stabilization service is that the practice is based on the prescribing physician's clinical judgment. Other people could have input, but it's really the prescribing clinician, the physician, who sets the tone and sets the orders for which way the protocols are going to go. In the past, when I was given protocols and programs called up and said, could you give us a protocol for this? My answer was usually no, and that I like the doctor to be comfortable with what they come up with. My job was to make sure that it was safe. So for the treatment of withdrawal for alcohol, one could use Librium, Ativan, the anticonvulsants such as Tegretol, being careful with the adverse effects of Tegretol. Opiate withdrawal, if you have a license, you could use methadone. Buprenorphine works very well. Clonidine works well. Naltrexone. The sedatives are a little tricky. It's easy to substitute with phenobarbital or actually pick the sedative the patient is on and be in control of how they use that sedative. And then you have nicotine withdrawal, where you could use nicotine replacement therapies, Chantix, Zyban. Cannabis has always been a little tricky and sort of we don't really quite know what to do. There is some study of gabapentin for the treatment of cannabis withdrawal. And what we found with 1,200 milligrams a day of gabapentin, less withdrawal and improved executive function. The stimulants are difficult to treat across the board. Again, the patients come in with anxiety. You could use anti-anxiety medications, certainly adjust meds for sleep, and if they're depressed, give antidepressants. In the stabilization part of this, it's a lot of the same medications. Alcohol, once they're relatively stable on your meds, you could use Revia or Vivitrol, which is a naltrexone-based medication, or Campril, which is a Camprosate. For opiates, again, methadone for a short period of time, buprenorphine or naltrexone. Nicotine replacement therapy works well for people who are nicotine dependent. Certainly the combination of nicotine replacement therapy and Zyban works even better than those used alone. And Chantix is also being looked at with the use of Zyban. Cannabis, the only medicine we've tried is gabapentin, and like I said, with the stimulants, all bets are off really is what's going to work really well to treat the patient. Buprenorphine is relatively new. It's been out since 2000. It is a really good medicine for immediately making the patient comfortable, setting the dose, and then slowly tapering. And again, no great rush in tapering the patient off. Buprenorphine can be used in an opioid treatment program along with methadone, depending on what the patient wants, needs. And it could certainly be used in an 822 or an 820, an outpatient program. Works really well and doesn't really negatively impact psychosocial treatment at all. Patients do really well. One of the bad, incorrect myths about methadone was that you could pick out somebody in group therapy who's on methadone because they're nodding off. And that's really not true. If the methadone dose is the correct dose, and you could check by blood levels, the person, you wouldn't be able to tell who's on methadone. Frequently, the person who's nodding off is on a whole bunch of medicines, sleep medicines, antidepressants, or the group could just be incredibly boring and they're falling asleep in it. So you really need to look at the whole patient and not just blame it on one of the meds.
And in terms of the documentation, I think we also often look at it as that we're documenting for somebody else. And that, in fact, certainly as we're trying to establish just what are the metrics that we should be using in the field, it's important for you to be documenting the things that you find are important. What are the elements of care that you think are significant? Because then you're able to say to your regulators or your funders that these are the reasons for making the decisions that we're making. And furthermore, these are the milestones that I'm looking at in the patient care to see whether they're progressing in care, whether they're stable in care, or whether we need to change care.
Right. And the one last thing, just because it always gets misunderstood, is a program who's using protocols, they are either deciding to prescribe their medicine, dispense their medicine, or administer the medicine, and people get mixed up what this actually is. Prescribing means you write a prescription and the person gets it filled on the outside. Administer means you have the medicines on site and you give it to the patient. This you have to go through pharmacy law. And also dispensing means you actually put it into one of those little medicine bottles and give it, and it has to be labeled. So what our suggestion has always been, prescribe and really think second or third time around about dispensing or administering.
Steve, I was wondering if you could talk a little bit about what I think are two of the great challenges for prescribers. One, that you're going to be giving medication to a patient who classically has problems managing their medication, and two, your interaction with the patient on how you assess whether this is the right patient for it and how they're managing it. What's your experience there?
Well, you certainly have to take a good history and know what's happened prior to that. You have to take a history of how they're using their medications. I always like, it used to be a contract, now it's a treatment agreement, where you set the rules, but you also set the expectations so that it's not my one magical pill is going to cure your addiction. And that's been a problem in the addiction world, where the ultra-rapid detox was sort of advertised as you go through this 6-hour procedure and you're cured. You don't have to do anything. Well, you wish, but that's not the way it works. So you have to manage expectations. You're going to be on these medicines for a while. You're going to be in treatment for a while. Recovery is every day. So the patient has to sort of understand that you have to balance the risks and the benefits of the different medicines depending on their medical history. So it's relatively complicated. It's sort of the art of addiction medicine and not really the science so much. I think doctors may have a little bit of a difficult time in understanding that while they're the ones who are prescribing, it's a team approach. So the nurse has input, the counselors have input, and this is really valuable. One of the best ways to know about a patient is to read the chart, to see what's actually going on the days you don't have the patient or you don't see the patient. So I think it's a whole host of different.
I think that very often for the clinical team, that working with the physician on these kinds of issues is new for them. It's really a new practice. And recognizing what the physician's responsibility is in this, and ultimately, because he is putting his name to the medication and it is his patient, it does rest with him or her. But at the same time, what the clinician wants to do is have a relationship with the patient that allows for an honest discussion of how the patient is doing. One of the things that I've heard, and it's been my experience, is that patients experiment. How would you react to something like that?
Well, I think the reaction is that the patient is there for an addiction problem. They're doing what they're expected to do. It shouldn't come as any great surprise that they're going to play with their meds a little bit. I mean, the non-addiction patient in my general medical practice used to play with medicines, give other people their medicines when things worked, which is against the law. But so experimentation is just a way of life. I think you have to set your goals and your parameters at the very beginning. Certainly keeping track of meds, not writing for a huge amount of medications and seeing the person often. Use the drug screen not as a negative, but use it as something that says, wow, you have a drug screen that shows no use of alcohol or drugs, you're doing great. That's a positive approach, as opposed to have it be something that you're trying to catch the person using. So I think there's a lot of things that one could really do.
Right, and I think that to some extent, having these kinds of conversations when you first start to induce the patient, when you first start working with them, about the expectations, the things that we're going to see, the things that we can talk about, but also how you're going to respond to them. I think that it's important for you to say to them, listen, if we can't control this with the medication, that this isn't going to work.
Right.
We need to work on this together. Because I think that ultimately, patients really do want to do well. They would really like to do better with this. I know that very often what I've seen with patients is that they want to be off medications. And that I see as much experimentation with patients reducing their medications as taking too much of their medications, kind of feeling their way through it.
No one ever woke up and said, I want to be an addict. So it's sort of like, you're absolutely right. They, like the rest of everyone in the United States, wants the magical pill that takes care of my problem and I don't have to deal with it anymore. And unfortunately, you have to deal with this every single day. The physician has to not be the patient's buddy, but they have to give respect to the patient. And I think the addiction patient has long lost respect from lots of different parts of the medical community. So just being respectful wins you over and gets them to want to try to do well, if not for themselves, but for you as well.
And certainly it's the opportunity for the physician to lead the team, to be able to talk about what the expectations are, why they're making the decisions that they're making, and for the team to work together, whether it's the clinical team, the medical health team, or even the administrative team. Very often the person who the patient has the most contact with is the secretary or the administrator in the front of the clinic. They hear a lot of stuff. Everybody has to be on board with this. This is an opportunity for them to take a look at how the program operates, what their philosophy is, and how they're going to handle these issues.
Right. So if we want to leave you with some pearls at the end of this chapter, we really want you to do the best you could do for the patient. Always err on the side of safety. If you don't like how the patient looks or you're worried about something, move them up to a more intense service. Monitor their care and really document. We can't tell you enough. Document. Put down what you're thinking about this patient. It'll help you when you have to go back, and it will help anyone else looking at the chart.
I just want to say thank you to Rob and Steve. That was an excellent presentation on withdrawal management and stabilization services. We hope that this was helpful to you in making the decision to implement withdrawal management services in your program or clinic. If you're in a WASAS certified program and you've viewed this, we have on the screen the website address for the application for becoming designated as an ancillary withdrawal provider. Again, thank you to Rob and Steve, and to you, the viewer.